So, welcome everyone. Welcome to Medical Mondays with Dr. O. Welcome to the forum where we learn to better our health and to learn new things every week. I'm Dr. Toyin with a background in family medicine, HIV, and substance use disorder. Now the health officer for Prince George's County, and always excited to host Medical Mondays with Dr. O. Tonight, we have a special guest, someone very special and dear to my heart. My own daughter, Zarin Jose Zade, a physician, hematopathologist, and also anatomic and clinical pathologist. She's going to be talking to us tonight about disease entities that we've seen a lot more, and most of the time don't even understand why we've seen a lot more of this. Maybe we are diagnosing better. She'll be talking to us about leukemia, lymphoma, and multiple myeloma. I'm going to yield the floor to Zarin to properly introduce herself and educate us. The floor is yours, and welcome.
Thank you. Thank you, everyone, for joining. Thank you, Dr. O, for this introduction. As she mentioned, I'm a hematopathologist and an anatomic and clinical pathologist at Emory University in Atlanta. And yeah, I'm really excited to talk to you guys about leukemia, lymphomas, and multiple myelomas. I know these are kind of rare and more rare entities, but they're actually more common than we think. And yeah, I'm glad to have the opportunity to go over the overview. I'll try my best to lay the terms in as simple as possible, but sometimes, you know, it's going to be a little bit difficult. So don't feel free to ask any questions if you don't understand, if there's a terminology that you're not familiar with. I'm going to turn off the video and concentrate on the lecture. Sorry. Let me just see. Oh. Okay, I guess I'm not able to turn it off, but that's okay. Anyways, let's get started. So this is the outline of my discussion. So I'll go over introduction, overview of hematopoiesis, the classification that us pathologists use to diagnose hematolymphoid neoplasm, the symptoms and clinical presentations, and then I'll go over the overview of leukemias, lymphomas, and multiple myeloma. So hematopoiesis is the process that the body makes new blood cells. The body continuously makes new blood cells. It continuously makes red blood cells, which carry oxygen. It makes white blood cells that help to fight infections, and platelets that are responsible to clot the blood after we have an injury. In fetus, most of the hematopoiesis is done in the yolk sac and liver and spleen, but after life, it shifts to the axial skeleton and distal long bones, in the bone marrow of axial skeleton and distal long bones. So these are the types of blood that we have. So the red blood cells or erythrocytes, these carry oxygen and expel CO2. We have the white blood cells. In the white blood cell category, we have multiple different types of white blood cells. We have neutrophils, eosinophils, basophils, lymphocytes, monocytes, and plasma cells. And then we have the platelets or thrombocytes that help the blood clot. So for the lymphocytes, there are two general subpopulations of lymphocytes, the B lymphocytes and the T and NK lymphocytes. Morphologically, they look very similar, as we can see in the image above. These are a mixture of both B and T cells, but by morphology, we cannot really tell them apart. However, their function is quite different. So I'll go over their function, but just to give you some statistics. So B cells comprise about 10 to 20% of the total lymphocytes in the circulation. T cells are a bigger proportion. They're about 60 to 80%. And then the natural killer cells, they're about 10%. T cells are responsible to kill infected or early malignant cells, but they need to undergo maturation and selection process in the thymus. B cells, they produce antibodies that attach onto cells and pathogen and mark them for destruction. And then the NK cells, they are part of the innate immunity. They act similar to T cells, but they don't need to undergo a selection process or maturation. So they're, in a sense, the first line of this defense. And this is just a schematic view of the hematopoiesis in the bone marrow. So I'm not going to go over every different cell, but just to kind of give you like an overview. So we start with a pluripotent stem cell, which divides into myeloid stem cell and lymphoid stem cell. The myeloid stem cell gives rise to neutrophils, eosinophils, basophils, monocytes, red blood cells, and platelets. And then the lymphoid stem cell gives rise to plasma cells, B cells, and T cells, and NK cells. Some quantitative changes in the white blood cells. So various conditions give rise to increase or decrease in a particular cell line. Some of these conditions are due to, they're transient, and they actually resolve once the body has kind of corrected itself, if there's an infection or if there's some kind of external factor like a stress. But if there's malignancy, then obviously the count will not correct. Some conditions that are associated with increased neutrophils include infection, inflammatory response, stress, or hematologic malignancies. Conditions that are typically associated with increased eosinophils, they include skin diseases, parasitic infection, transplant rejection, but additionally hematologic malignancies. Conditions with increased monocytes, usually chronic infection like TB. Some leukemias with a strong monocytic component or bone marrow failure. And conditions with increased basophils, they're typically seen in myeloproliferative disorders, specifically CML, which I'll talk about in subsequent slides. Some hypersensitivity reactions, and also it's been known to increase in ulcerative colitis as well. So what is leukemia? Leukemia is a cancer that affects the blood and bone marrow. It's usually the result of excessive proliferation of hematolymphoid cells, including WBCs, RBC, or megakaryocytes. And pathologically, leukemias are divided into acute or chronic. I'll give you an overview of all of these entities in more detail. Lymphoma is a cancer that mostly affects the lymph nodes, or some solid organs that have a high concentration of mucosal associated lymphoid tissue. And plasma cell myeloma or multiple myeloma is a cancer of plasma cells specifically, and typically affects the bone marrow. Some common symptoms include bleeding, easy bruising, fatigue, fever, increased risk of infection, night sweats or chills, pallor or skin rash, lymphadenopathy or enlarged spleen, and then organ swelling, including the gums, the lips, or periorbital areas. So as a pathologist, this is my Bible. These are the WHO classification system. That's how the WHO is one of the most common classification systems that pathologists use to diagnose any type of cancer. And this is the specific volume for hematolymphoid tumors. And this is just like an overview of different types of hematolymphoid malignancies that are diagnosable. So all these different entities are a specific type of disease that we can diagnose, basically. And the chart on the left, these are mostly myeloid or WBC kind of cancers. And then on the left, these are basically the lymphoids, the ones that are mostly seen in the lymph nodes. So the ones on the left, I could say that they're mostly the leukemias associated with bone marrow cancers, and then on the right, they're mostly lymph node associated cancers. So leukemia, as we mentioned, it can be divided into acute and chronic. So acute leukemia is a rapid increase in the number of immature cells in the blood or blasts. It can also obviously be increased in the bone marrow and organs, but it's mostly increase of the blast in the bone marrow. So mutation in DNA stimulates the abnormal cell to replicate without being recognized by the immune system. This causes a proliferation of the abnormal cells, particularly the blasts. And then the expansion of this abnormal cells in the bone marrow reduces the different other cell lines, which causes anemia and cytopenia. So that's why patients with hematolymphoid neoplasms or leukemias particularly, they tend to have anemia because their red cell line will be decreased, or their megakaryocytes, which produce platelets, will be decreased. So usually we have abnormal indices in the normal routine CBC that we perform. Immediate treatment is required because of this rapid progression, and accumulation of the malignant cells causes significant morbidity. Some examples include acute B lymphoblastic leukemia, acute T lymphoblastic leukemia, acute myeloid leukemia, or acute mixed lineage leukemia, which can be both B myeloid or T myeloid. Acute leukemias account for 50% of all leukemias in clinical practice. Leukemia is the most common childhood cancer, and acute lymphoblastic leukemia accounts for 70 to 80% of all leukemias in children, particularly aged 3 to 4 years. Acute myeloid leukemia, however, has a biphasic distribution, and it's more common in elderly patients, about 15 per 100,000 annually in adult population or elderly patients. And the peak is the 7th decade of life. So this is an example of a patient with acute B lymphoblastic leukemia, which, as we mentioned, is the most common childhood type of leukemia. And as we can see clinically, we'll see periorbital and perioral swelling, typically easy bruising, gum swelling, gum bleeding. And then in the peripheral blood, we can actually appreciate this really increased population of these really large cells. The cells look very monotonous, and they have a really, really high nucleus. So this is the nucleus of the cell, and this is little rim of kind of darker blue is the cytoplasm. Normally, we want to see more cytoplasm compared to the nucleus, but here in blast, which are these cells, we actually see that the majority of the cell consists of the nucleus. So this is like one of the characteristics of blast, this high NC ratio that we call. So the diagnosis of acute leukemia typically starts from a clinical suspicion rather than as a result of routine CBC. So if the clinician suspects acute leukemia, the first thing they will do is draw blood and send us for routine CBC. If the CBC comes back with really elevated WBC counts, usually that's there are less common type of leukemias like erythroid, which is like a red blood cell leukemia, or megakaryocytic, which is like kind of like a platelet line. But majority of the leukemias are WBC driven, so the WBC count will be really high. So then the next step is to kind of further characterize what kind of WBC. As I mentioned, we have about 9 different type of WBCs. So we have to see if they are like myeloid, like neutrophil lineage, or they're lymphoid, like B cells or T cell lineage. So the one thing we can do is the flow cytometry. So flow cytometry is like a machine that the cells are passed through a chamber, and there's a light transmission or laser transmission, which kind of fluoresces with a type of antibody that we add to the blood, and that allows us to further characterize the cells. So if we see, yes, there is like an abnormal population of like one of the cell lines, then the next step is to do a bone marrow biopsy, and it's usually done, like the iliac crest are the most common site of bone marrow biopsy. Once the biopsy is performed, then the specimen gets sent to the lab, to the pathology lab, and there we process the specimen, and we can make these slides where the slides are given to the pathologist, and under the microscope we can make the diagnosis basically by reading the slides. And that was like a very simplistic way. There's numerous other tests that we perform. We can perform immunohistochemistry, molecular tests, cytogenetic tests, all of these to help us further make a more precise diagnosis. So ALL management is usually encompasses induction therapy and consolidation or maintenance therapy. Induction is aimed at reducing the number of cancer cells as quickly as possible to achieve remission. Sorry, does somebody have a question? Oh, okay. So induction therapy is aimed at reducing the cancer cells to achieve remission, and then consolidation or maintenance is to avoid the relapse. So in induction therapy, kind of the management changes slightly from younger to like older patients. So in younger patients, we can do clinical trials. We can have pediatric a specific chemotherapy regimen, or we can also do multi-agent chemotherapy. In elder patients, yes, we can do all of that, but if there is a lot of comorbidities, then the management changes to more of a palliative type of regimen, and giving palliative steroids is usually performed by the or given by the clinician. Consolidation and maintenance. Again, the management is divided into younger and older patients. In younger patients, allogeneic hematopoietic stem cell transplant is usually the first line of consolidation. But if the patient is not prone to stem cell transplant, if there's no donor available, then we can give chemotherapy. In older patients, chemotherapy is usually the first line consolidation, but if the patient is a good candidate, then we can also pursue with a stem cell transplant. Okay, for chronic leukemias. So is again characterized by excessive buildup of mostly mature type of neoplastic white blood cell. However, the difference is that because these cells are mostly mature, the cancer is not as aggressive than acute leukemia. And initially, the patients can be monitored, but usually a lot of these chronic leukemias actually kind of, as they progress, they become acute leukemia. So at some point, the patient does need to undergo treatment. The most common type of chronic leukemia is chronic myeloid leukemia, or CML, which most of the physicians on the call are familiar with. Additional ones are chronic neutrophilic leukemia, chronic eosinophilic leukemia, or chronic lymphocytic leukemia as well. The diagnosis is very similar to Acute leukemias, again, it involves the CBC, doing a bone marrow biopsy, flow cytometry, molecular and cytogenetic studies. So clinically, a patient with chronic myeloid leukemia typically presents with systemic symptoms as well as organ-specific symptoms. So for systemic, they usually have weight loss, fever, frequent infection, fatigue, loss of appetite. And then for organ-specific symptoms, they have shortness of breath, weakness, bone pain or tenderness, hepatosplenomegaly. They can have lymph node enlargement, lymphadenopathy, night sweats, easy bleeding, bruising, and then they can have purplish patches or petechiae on their skin as well. And here, just for comparison, this is a peripheral blood smear from a patient with CML as compared to the blast cells, which I showed earlier. Again, we have a lot of white blood cells here, but they have like a spectrum. They're not mostly all like that monotonous type of blast population, but we actually have a spectrum. You know, some cells, they look like maybe they're blast, but their other cells are like maturing, and then we have this neutrophils. You know, these are the most mature type of like myeloids. One of the myeloid lineages is neutrophils. So these are the most mature ones. So we have a spectrum of white blood cells or neutrophils here. So CML has three phases: the chronic phase, accelerated phase, and blast phase. The chronic phase is the most indolent phase, that where the patient can, you know, essentially be just monitored. But accelerated phase is like a progression towards acute leukemia, and then the blast phase, if the blast percentage is more than 20%, then this is typically considered as an acute leukemia. So first-line treatment for CML is giving a tyrosine kinase inhibitor, such as imatinib or dasatinib. We can also give hydroxyurea that lowers the WBC count, and also considering patients for stem cell transplant, if the patient is TKI resistant particularly. So now I'm going to talk about lymphomas. So as the name implies, lymphomas are kind of like hematopoietic neoplasm of the lymph nodes. And the lymph nodes is where most of the B and T cells exist. So that's like a lymphoma of the B and T cells, or less commonly NK cells. So they can arise from the lymph node, or they can also arise from some organs that have a high number of mucosa-associated lymphoid tissue. So they're not like a lymph node per se, but they have a lot of lymphoid tissue, like the GI system, and the lymphomas can also arise from there. So again, this is what I showed earlier. So this is the classification for lymphomas divided into B cells, T cells, and T and NK cells, and then also Hodgkin lymphoma. Another clinical, in clinical practice, however, we lump the B and T cells as non-Hodgkin lymphoma, and then we also have the Hodgkin lymphomas, which are, again, kind of what most of the clinicians here, when we talk about lymphoma, like that's usually what they think about, like Hodgkin lymphoma. So this is a histology. I'm a pathologist, so I have to throw in histology wherever I can. So this is the histology of normal lymph node. So we have a capsule with some adipose tissue that usually surrounds the capsule. And then in the cortex area, we have these follicles. These are the lymphoid follicles. These are like these round structures in the follicle. That's where most of the B cells originate from. So the follicles produce a lot of B cells. And then in the interfollicular spaces, that's where after the T cells mature from the thymus, they actually go to the lymph node and they exist within these interfollicular spaces. So most of the B-cell lymphomas, they arise from these lymphoid follicles, and most of the T-cell lymphomas, they arise from the interfollicular spaces. So non-Hodgkin lymphomas, they're due to a clonal malignant proliferation of mostly B or T cells, less commonly NK cells. And as mentioned, they arise usually from the lymph nodes, but they can also expand into the blood or bone marrow. It accounts for approximately 74,000 new cases per year in the US, and it's 5 times more common than Hodgkin lymphomas. And also it's most commonly seen in elderly patients over 60. These are some examples of the most common B-cell and T-cell lymphomas. So for the B-cell, the most common lymphoma is chronic lymphocytic chronic lymphocytic lymphoma, or CLL. Follicular lymphoma, diffuse large B-cell lymphoma, marginal zone lymphoma, and Burkitt's lymphoma. So Burkitt's lymphoma, I think most folks from Africa or Papua New Guinea have seen cases of Burkitt's lymphoma. So Burkitt's lymphoma has 3 subtypes. The endemic type is very common in endemic regions such as Equatorial Africa and Papua New Guinea. And it's caused by Epstein-Barr virus infection, which actually causes this lymphoma, especially in children. And T-cell origin lymphomas, some of the most common ones are peripheral T-cell lymphoma, anaplastic large cell lymphoma, mycosis fungoides or Sézary syndrome, and hepatosplenic T-cell lymphoma. As mentioned, this is not a comprehensive list. The list, as I showed you, is quite extensive, but these are just some of the most common types of lymphomas. Again, just to show you the histology of how we actually diagnose these lymphomas. So like follicular lymphoma, when we see a sample that shows mostly like back-to-back follicles without any interfollicular space, and we see that kind of like the follicles look abnormal, they don't have a good polarization, so like they don't have a paler central area and a darker rim. It actually looks like the follicle looks kind of monotonous. That's like one hint that, okay, we are probably dealing with a follicular lymphoma, and then we will do additional immunohistochemical and molecular testing. For diffuse large B-cell lymphoma, the histology looks quite ugly. The cells are very large. They have a very prominent like nucleoli, like so in the center of the nucleus, they have a nucleoli that becomes quite prominent to see. Small lymphocytic lymphoma or chronic lymphocytic leukemia, it's the same entity. It's a small cell proliferation, so the lymph node kind of does not have that nice architecture. Like we cannot appreciate the follicles, but it just looks like a diffused sheet of small cells as seen here. And this is a histologic representation of Burkitt's lymphoma. It's typically kind of like described as the Astorius sky representation by the Van Gogh drawing of Astorius sky, and that's because we have this kind of like sheets of I guess medium-sized blue cells, but we have tingeable body macrophages intermixed, which give us that like Astorius sky appearance. And then this is an anaplastic lymphoma. So as the name implies, anaplastic or very pleomorphic or very, I guess, irregular. So the cells are very large, kind of like ugly looking, and they don't really have any orientation. So it looks very kind of like ugly type of cell. Now I'm going to talk about Hodgkin lymphoma. So Hodgkin lymphoma arises from a special type of germinal center B cell known as VIDEM cells. And this is like a representation of VIDEM cells. So these are, the cells are these binucleated cells that are typically described as resembling owl eyes. So in pathology, we use a lot of like mnemonics and representation. So whenever we see, okay, owl eyes or cells resembling owl eyes, we always think, okay, probably Hodgkin lymphoma. As far as clinical presentation, it usually affects young adults, usually age 30 to 40, and the patients typically present with supraclavicular or mediastinal lymphadenopathy rather than diffuse lymphadenopathy. And by histology, we can divide it into classic Hodgkin lymphoma or nodular lymphocyte predominant Hodgkin lymphoma. So these are the two types of Hodgkin lymphoma that we can basically categorize based on the WHO. Treatment, the standard treatment for Hodgkin lymphoma is ABVD regimen. So it's a combination of doxorubicin, bleomycin, vinblastine, dacarbazine. Sometimes direct a specific site radiation can also be given. As for prognosis, so non-Hodgkin lymphoma, the 5-year relative survival rate for patients for non-Hodgkin lymphoma is 71%, and prognosis depends on several factors, including the tumor histology, tumor bulk, tumor stage, presence of extranodal disease such as brain involvement, and age of patients. The prognosis for Hodgkin lymphoma is much better. The 5-year relative survival is approximately 90%. And again, the prognosis depends on age of patients. So younger patients have a really, really high survival rate as opposed to elderly patients, which the survival rate is about 60%. And then also tumor stage. And now I'm going to talk about plasma cell myeloma or multiple myeloma. So this is just like a pictorial representation of the most common symptoms that the patients present with. So they have a bone pain, usually bone fracture. They have anemia, repeated infections. There's raised calcium levels. Sometimes they can have unusual bleeding. The blood becomes really thickened or viscous. And also patients present with renal failure. And this is a image of plasma cells like that we typically see in plasma cell myeloma. So as mentioned, it's a hematologic malignancy of plasma cells. So the function of plasma cells is to produce antibodies or immunoglobulins as part of humoral immunity. However, myeloma cells produce abnormal immunoglobulins. As a result, there's increased risk of infection because the antibodies that the plasma cells are producing, they're not effective. They cannot fight infection. Also, when the plasma cells produce antibodies, they also produce additional proteins as well. And these proteins are called light chains. They deposit in other organs, including the nervous system, and that's why we have neuropathy. They also can deposit in the kidneys. That's why we have renal failure. As well, the proliferation of the plasma cells in the bone marrow, again, kind of like the space in the bone marrow is limited. So when one cell line proliferates, then it reduces the other cell line. So we have anemia as a result of that. Also, we have destruction of the bone because abnormal plasma cells, they activate osteoclasts. So osteoclasts are a type of cell that are responsible for resorbing bone or decreasing bone density. So because these cells get activated, that's why we have the bones becoming more fragile. And these are the subtypes of multiple myeloma. You know, we have a smoldering myeloma, which is asymptomatic, non-secretory. And then if we have a lot of plasma cells that have emerged from the bone marrow into the blood, we can have a plasma cell leukemia. That's kind of very end of stage. Again, just to kind of go over the symptomatology of multiple myeloma, as mentioned, Due to marrow infiltration, we have anemia. Due to osteoclast activation, we have lytic lesions and pathologic fractures and hypercalcemia. Due to reduced effective antibodies or immunoglobulins, we have repeated infection. Due to accumulation of these monoclonal proteins in other organs, we can have renal failure, the blood becomes viscous, and we also have amyloidosis, which is, again, basically light chain deposits in the other tissues. For epidemiology, multiple myeloma accounts for 1.8% of malignant tumor diagnoses in the US annually, and it accounts for 21% of deaths of hematopoietic malignancies. Has a male to female ratio of 1.2 to 1. It's twice more frequent in African American population compared to Caucasians or Asians. It's typically not seen in children or young adults and has a median age of diagnosis of 70 years. And there's a potential genetic predisposition with increased risk in first-degree relatives. For clinical features, again, bone pain and fracture is the most common initial clinical presentation. But as mentioned, patients have renal failure, elevated creatinine, hypercalcemia, recurrent infection, and anemia. So again, some histology, these are some of the acute but abnormal presentation of atypical plasma cells. So we can see some that have cytoplasmic inclusions. We can see some that have multinucleation, and then some that, I don't know, looks like a turtle, and some that look like a blast. Treatment options for patients with multiple myeloma. The initial myeloma-related therapy involves like myeloma-related monoclonal antibody as well as bone-targeting treatments. So the first line is usually daratumumab or lenalidomide or bortezomib. These are monoclonal antibodies that target plasma cells. And then dexamethasone, which is a steroid given for basically reducing inflammation in the bone. Other regimens exist as well. And then, additionally, we want to assess patients for hematopoietic stem cell transplant. As for prognosis, multiple myeloma prognosis has improved significantly, with many patients now living 10 years or more, which definitely was not the case about maybe 10, 15 years ago. And the overall 5-year relative survival is approximately 62%. Prognosis depends on early detection, with survival rates up to 80% if the disease is detected early. Additionally, it involves a stage, age, and cytogenetic risk factors, which some cytogenetic risk factors they have a poorer prognosis. Some predisposing factors for hematolymphoid neoplasms in general. So genetic or chromosomal abnormalities, specific translocations can cause lymphomas or leukemias. For example, CML is due to a specific translocation in chromosome 9 and chromosome 22, which causes CML. For example, Burkitt's lymphoma, again, it's due to a specific translocations in chromosome 8 and 14 involving the MYC gene. Some inherited cancer predisposition syndromes or congenital anomalies like Down syndrome, Fanconi anemia, ataxia telangiectasia. These can predispose to presence of like hematolymphoid neoplasms. Chemical exposure such as benzene, some pesticides, or previous chemotherapy agents. Again, they can increase the risk of hematolymphoid neoplasm. Viral infections such as EBV, human T-cell leukemia virus, or some hepatitis C, hepatitis C that can predispose to some B-cell malignancies. Immunodeficiency or immune dysregulations like HIV/AIDS, post-transplant immunosuppression, and primary immunodeficiency syndromes, they can also predispose to hematolymphoid neoplasm. autoimmune or chronic inflammatory disorders, so Sjogren's syndrome, rheumatoid arthritis, celiac disease. These are typically associated with more of like a small B cell neoplasm, especially marginal zone lymphoma or MALT. And age, as mentioned, most of these hematolymphoid neoplasms, they arise in more elderly population as opposed to younger patients. And then lastly, family history. So having a first degree relative with leukemia or lymphoma can increase your risk as well. And these are my references, and thank you very much. I'm happy to take any questions.
Well, you did all of that in one session. That's a lot. Thank you. Thank you. That was fantastic. So if you please put down the slides, it would help me more to be able to see when people raise their hands. So if you have any questions, please raise your hand to ask or put in the chat box. That was loaded. You know what I was looking at and looking for mostly when you were presenting is the cause, prevention. But we can see that most of the causes there are not self-induced or self-imposed because you cannot change your genes, correct?
Yeah.
You cannot change genetic genetic distribution or what you inherited. And so how do one manage in this terrain if somebody is diagnosed with all of this? What would be your counsel?
So as you mentioned, unfortunately, like most of the leukemias or lymphomas are genetically driven. However, some of them are, I guess, inflammatory driven. Specifically, for example, like some B cell neoplasms. So they're associated with like chronic inflammation. So, for example, in patients with Sjogren's or some kind of autoimmune disorder, this like chronic inflammation kind of predisposes you to developing a lymphoma. So I think managing that, if patients are constantly, like their white counts, basically they don't manage the autoimmune disorder or the inflammation part, that can kind of proliferate, that can signal the lymphocytes to proliferate excessively. So basically managing the inflammation, managing the underlying condition like Sjogren's syndrome, or even Helicobacter infection, like Helicobacter infection in the stomach, that can also predispose to marginal zone lymphoma. So if you know that you have some kind of like infection or Helicobacter, which is very, very common, it's probably the #1 cause of dyspepsia in the U.S. Or dysphagia in the U.S. Like basically addressing that, I think those are some of the more manageable type of treatments that we can have. The ones that are not kind of genetically driven. So I think that, and also reducing, exposure to kind of chemicals like, benzene, pesticides, or some kind of like some dyes with really strong smell, like cleaning supplies, those things. So like maybe just like wearing a mask and being kind of mindful.
Wow, thank you so much. That was very important. So inflammation, you said when somebody has inflammation not treated, it can cause proliferation, meaning that it's like the cells now reproducing, and multiplying to cause this problem. So I think the take home for me in what you just said is it's best when one notices there's anything wrong with the body to go check it out, to go to the
Definitely.
doctors to
Yeah.
know what is going on and not, try to treat oneself, at home. Auntie Tawa, welcome, Auntie Tawa is all the way from Tampa, Florida. Welcome, kindly
Welcome,
unmute to
Dr.
ask a
O
question.
and Dr. Jose Insa. I'm sorry if I messed up your name.
Sure, no problem. Call me Zara. That's that's easy now.
Okay. Thank you very much for your presentation. Very detailed and very medical. So if somebody has some of this myeloma or anything, and is it possible that if one person in the family has it, the siblings can get it, or does not work like that?
It's not so it's not a contagious disease. Just to clarify, so this is not a contagious disease, but there is genetic predisposition. So like if there's a higher chance that if somebody in the family has it, then the genes that that person harbors, like you may also have attained the same genes. So it's your chances are higher, but in the sense of being contagious, it's not. It doesn't mean that if somebody has it, then if you're around them, then you will also get it.
Yeah, thank you. Then the second part is if somebody...
Auntie Tawa, before you continue, genetically though, they can be predisposed, right?
That is what I'm asking, not that it's going to be transmittable, like you touch the person or you, no.
Not like
I'm telling you, in their DNA, in their genetic DNA.
Yeah. Go ahead, Zara.
Yeah. No, I was just saying that there's a genetic component, yes. So that like at the current moment, like it's not like like GYN cancers or breast cancer. We don't typically test families. If somebody is diagnosed, we don't necessarily test families unless they want to. But we would test families if at the time of like if you're assessing transplant candidacy for that. But the risk of genetic is not as high as some of the other cancers, I would say.
And is it possible that if you go into remission, is it possible to come back? And what is the length of years when you can say, okay, I'm done, it's not coming back anymore? Or is it forever that?
No, unfortunately, the remission is not forever, unfortunately. And that's why when somebody is diagnosed and they have achieved like remission, the clinical team, they usually do very strict follow-up. Like they would do, I think monthly, like depending on what's the diagnosis, they would do monthly or like every 6 months biannual checkup to make sure that the counts are within normal limits.
My question is, when will that person be? Because I know someone that had all this problem when she was 3, 4, and now she's 16. Nothing has happened. Is she out of the wood, or we should still be monitoring the situation?
They definitely should monitor. Yes, I mean the prognosis for children is much better. Like if they have achieved remission, the chances of them maintaining a remission is much higher than in adults. But if you have this diagnosis once, you have to be really vigilant to your symptoms. Like if they notice even a slight skin bruising or like gum bleeding or like easy bruise, so basically they need to remain very vigilant. And also, I mean, the clinical team will have a better idea of how strict they need to be monitored. So they definitely need to follow up with that regimen.
Thank you very much. I appreciate you. Thank you.
Thank you. Dr. Dija.
Yes,
Kindly
good
unmute.
evening,
Good evening.
Doctor. Good
Welcome.
evening, and thank you always. Thank you so much, Dr. Zizi, for this presentation. I'm Dr. Khadija, pharmacist, community pharmacist on Dr. O Forum. I just wanted to bring it to perspective in the area of community setting, right, or even in primary care. What would you say are the very quick red flags or early red flags, if you will, that will prompt a referrer to say, go check, I'm suspecting leukemia or lymphoma?
I think
Excellent question.
clinically, yes. I mean, I have to, give this disclaimer again. I'm a pathologist. I'm not a clinician, so I don't really know
Sorry,
how
I
to
missed the
finish it,
beginning of your introduction. My bad.
No. Yes, of course. But I mean, the most common symptoms that I see, like when I'm making diagnosis, like the most common symptoms that I see in patients' charts is like, this patient came in with weight loss and like fatigue, paler, like whoever is coming with unconditional, unintentional weight loss, fatigue, paler. I think a lymphoma has to be in the differentials, and they need to get a CBC. I think, I guess the screening for a hematolymphoid neoplasm is a CBC. So definitely, when there's a clinical suspicion, just get the routine CBC, because that really, I mean, obviously, some lymphomas are not, diagnosed based on the CBC. Leukemias are, but lymphomas is usually, at least initially, it's mostly contained within the lymph nodes. So again, if the patient doesn't have lymphadenopathy, then it's less likely that they will have a lymphoma, but do a CBC to see if they don't have a leukemia, because leukemias, they don't necessarily have lymphadenopathy.
Okay,
but
thank
yeah,
you.
I think unintentional weight loss, fatigue, paler, easy bruising or easy bleeding, I think these should really prompt the clinicians to think of that as a differential.
Okay, thank you. And also, just to borrow from Ms. Towers, when you were responding to her, or was it Dr. O responding to her about inflammation, does this include generalized inflammation, or did you mean maybe there's a source of bruise and then it's inflamed, or just generalized,
It's a very chronic inflammation. So usually the patients have some kind of the inflammation for years, especially in the setting of some of the most established association with inflammation and lymphoma has been Sjogren's disease, because there's a lot of inflammation, especially in the salivary glands, because the salivary glands don't produce, the patient has dry mouth. So around that salivary gland, there's a lot of immune attack, I would say, or they have dry eyes, due to the overreactive lymphocytes that are causing the meibomian glands to, degenerate. And that kind of inflammation over years, I would say maybe more than 5-10 years, that really is known as one of the predisposing factors for marginal zone lymphoma. Marginal zone lymphoma is a very indolent lymphoma that is known to arise as a result of really chronic inflammation, and then H. pylori, Helicobacter pylori organism in the stomach. If it's not treated, that's also over years that causes a lot of inflammation in the stomach. So it's also associated with marginal zone lymphoma in the stomach.
Okay, thank you so much.
No problem.
Diagnosing this can be dicey because people would have symptoms that are flu-like. You will say, they have fevers, they have fatigue, and in the initial stages, or even when it's still progressing, it can be a little bit challenging because it can be overlooked as it is something else. until, you know, they have persistent symptoms. If they start having bruising easily, or having, you know, petite. How do you explain petite? Zari, petite?
They're like spots. They're like tiny spots on the
on the
skin.
skin, like reddish spots on the skin. Then it can prompt a primary care doctor like me to decide to do, you know, the basic blood work to check the red blood cells, white blood cells, and see what is going on. And, you know, those would then be the telltale signs. Regardless, if somebody is having fatigue, people can even have bone pain, you know, and a lot of people may think, oh, that they're overworking or explain their pain away. I think it's always best to just let a physician evaluate situations and then make the call. But it may not be clear-cut, especially in the beginning. Just because the symptoms are not specific. Does that make sense?
Yeah. They can be subtle, very subtle.
It can be subtle. That's why we're having this conversation, so that, you know, things are not overlooked. So there's a question in the chat box from Bridget. She said, well, she actually asked 2 questions, and I missed one before then. She said, what are the final stages of leukemia? That was the first one. Final stages of leukemia. I don't know what that question really means.
Yeah.
Okay, so that would be an advanced case of leukemia, and it's always not good to have final stages of anything. So it will be the last stages, I would say. There's another question that says, what are the chances that if someone is born with AS, someone is born as AS, you know, they have the sickle cell trait, and the S factor is higher, will that person be predisposed to develop leukemia in their lifetime? No.
If they have sickle cell trait?
Yeah. I've never,
no, I don't an association with sickle cell trait.
There's no linkage.
No.
It has nothing to do with leukemia. Okay, so another question from Bridget says, from all your presentations, you made clearly that living with leukemia or any blood cancer involves a complex emotional journey with different phases triggering specific feelings. What is best advice to individuals with chronic leukemia? What advice would you give them?
So again, for patients with chronic leukemias, as mentioned, those go, like, they have phases. So I think the most important thing would be to follow up, like do a very strict follow-up with the clinicians to avoid the progression. So basically, you know, trying to avoid the progression, limiting, I guess, the stress, limiting inflammation, infection. So like, because any kind of a stressor is also known to maybe kind of like tip the cancer into like a more advanced stage, like to cause it from being in the chronic phase to like accelerated phase. So trying to really avoid, I guess, stresses, environmental stresses, but also, you know, as mentioned, most of these are kind of like genetically driven. So that part we cannot really control, but I think doing strict follow-up to make sure that even if your counts, like, for example, somebody with CML may have maybe like, you know, 2% blast, but, you know, the next time that they go get checked out, then the count has increased to like maybe 5% blast, and then they really need to see or evaluate their therapeutic options to kind of try to control it very early on. Also, there's like molecularly we can assess for like a specific type of protein that are circulating in the blood with for patients with chronic leukemias, also that's like something that the clinicians monitor to see that if there's increases of that specific type of like protein in the blood. So I don't want to get into like the specific nitty-gritty part, but I think, you know, to answer it, you know, avoiding environmental stressors and also doing strict follow-up with the clinical team to make sure that the counts are still like within normal and they're not like increasing.
Yeah, I agree. And with any disease entity, emotional, I'll call it trauma, is inevitable. Because there's always, you know, why me? And, you know, none of these treatments are easy. Even the diagnosis is not easy. So navigating the period with counseling is important. You know, talking to a therapist, getting counseling. The person may even need some medication to treat things like anxiety, depression, and stuff like that. But paying attention to mental health is important. That's a very good question, I think. Navigating any disease entity, any chronic disease entity is not easy. It can be mentally tasking. But I want to remind everyone on the platform that we are not establishing care, physician, patient interaction on this platform. We are sharing cogent, correct medical information, but not establishing care. Dr. Izugo, kindly unmute. Fantastic.
Yeah, thanks again for your wonderful presentation. I have more of a question to do with teleinterpretation of pathological reports. Do you guys like do anything like that for, let's say, for third world countries, you know, like if they did a biopsy or slide and really want expert interpretation, you know, from your department? Can you guys help with things like that with no legal incumbent and stuff like that?
You mean with no legal implications?
Right. You know, it's more of an educational interpretation of something, you know, and then the decision of management and whatever, you know, becomes a local, you know, jurisdiction on licensing and stuff like that, just more of educational collaborative discussion on a slide of pathology.
So I think I have to discuss with the leadership to see if we can facilitate that. I know some universities, they do have this kind of collaboration, kind of pro bono with more like third world resource limited countries. I have a feeling Emory also does that, but I am not really familiar with the legalities, but I can definitely ask and follow up with Dr. Opasami and let you know.
And that'd be great. We appreciate that. And thanks again. That was a wonderful presentation. Appreciate you.
Thank you.
Thank you.
Yes.
Thank you. Your presentation was fantastic, deep. You took us to the pathology, the physio, everything. It was very, very robust, comprehensive. We appreciate you. And I want to, you know, revert back to you to ask, what would be your parting words for us? If there's one thing we should take home in your presentation, what would it be? What's the advice you will give us on the platform as take home?
Putting me in the spot.
And I know that's a tough one, because what you did was presented three major cancers. That's a lot. So I'm asking a very difficult question for you to now put it together into one take home. So pardon me, but I just want us to have a take home message.
Really, for not just like particularly specific to my presentation, but I think for anything, like, I honestly think, yes, it's good to stay informed and, like, you know, go on Google and, like, try to search entities or, like, symptoms. But it's really important in the era that we live, it's for us to kind of be able to vet misinformation and not to get panicked. So I think I would encourage, like, everybody, whenever they hear something or they have, like, a symptom, like, don't necessarily think, like, for example, I discussed, like, lymphadenopathy as, you know, one of the maybe, like, symptoms of lymphoma, but not all lymphadenopathy is lymphoma. You can have a swollen lymph node and it can just be infectious. So really don't, you know, panic. Don't try to diagnose yourself, and really leave it to the experts. And even in the worst, like, situation, I think staying calm and, you know, staying calm is probably the best thing. And yeah, like, definitely avoid, I guess, getting panicked and, like, diagnosing yourself, and just because you read something on the internet.
Thank you so much. Be careful of Dr. Google.
Yes.
That's what you're telling us. Thank you. Thank you so very much. We appreciate you.
Thank you. My pleasure. Thank you.
I want to, you know, just encourage everyone on the platform that we take the advice we've been given. Until we meet next week, please stay safe, stay well, and we'll see you next week by the grace of God. Have a blessed night.
Thank you.
Yes, bye.
Thank you,
Thank
everyone.
you. You
so
too,
much.
stay well and take care of yourself.
Yeah.
Auntie, do I look better?
Madam Lara, you are with me, right?
Oh my gosh.
There's
Recording
Tower
stopped.
don't cause trouble.
No.
How are you?
No.